Good evening to everyone present here with us today. This is Shriyan from IGCP, today's moderator. I would like to welcome a very renowned doctor who have joined our platform for better exchange of knowledge that is going to be shared by your keynote speaker, doctor. With much pleasure and honor, I would like to welcome Dr. Arun Raghavan. Sir is the director and consultant diabetologist at Dr. A. Ramachandran Diabetic Hospital, Chennai. With the help of Sir and his wonderful insight, we will be taking a close look on today's topic, which is overview of newer anti-diabetic agent. Now, without any further delay, I would like to welcome Sir at our forum and would like to hand over the session to him. Over to you, sir.
Thank you so much. At the outset, I would also like to thank IJCP for having invited me for this online discussion. So I was thinking of contemplating what could be perhaps one of the best topics at this point in time is that the newer agents that are actually in the pipeline for managing diabetes. As we know, the paradigm for managing type 2 diabetes has considerably changed in the last decade or so, right? Earlier, we did have robust, powerful molecules. We had the sulfonylureas. We also had the DPP-4 inhibitors, insulin, metformin, so on and so forth, which were able to reduce the blood sugar, right? But the last decade, we had molecules such as the GLP-1 receptor agonists. We had the SGLT2 inhibitors, which have perhaps broken the glass ceiling, right? They weren't just able to reduce the blood sugar levels, but they were able to offer extra glycemic benefits, right? They were able to address the entire metabolic spectrum. SGLT2 inhibitors, if in fact you've seen from some of the trials, they were not just reducing the cardiovascular mortality, but they were reducing the heart failure risk, not just in the reduced ejection fraction group, but also in the mid-range and preserved ejection fraction group, which none of even the cardiac medicines were able to do, right? So SGLT2 inhibitors were game changers on that note, right? None of the cardiovascular medicines till date, including the valsartan, sacubitril, beta blockers, ivabradine, digoxin, name the drug, they have impact in the reduced ejection fraction. None of them had any impact in the preserved ejection fraction, right? So that's the kind of impact that SGLT2 inhibitors have actually brought into a patient living with diabetes. Today, we can actually tell here is that I'm giving you a drug which can actually modify your cardiovascular risk, confer cardiovascular protection, and on top of that, even renal protection that we are all are cognizant of. Similarly, GLP-1 receptor agonists, although they were quite expensive, they were only a handful of prescribers about a decade back earlier. Now they've really penetrated, right? Now we know that GLP-1 receptor agonists not just have an impact on diabetes, but they also kind of address the entire spectrum, as I mentioned, including body weight. They have a huge impact on the BMI of a patient. Now, certain molecules that I'm going to discuss, in fact, are as effective as a bariatric surgery, probably helping not just in controlling diabetes, but also possibly resulting in such profound weight reduction that bariatric surgery may be a thing of the past. Right now, so to come, I've already mentioned this introduction. We can go on to the next slide. Right. So, next slide. Yes. So some of the emerging drug classes, as I've already alluded to, we have the SGLT2 inhibitors on the table. We have the GLP-1 receptor agonists already, right? We have the liraglutide, which probably was liraglutide and exenatide were the first initial molecules that were rolled out. Subsequently, we had the lixisenatide, and then we had the once weekly dulaglutide. We had the once weekly exenatide, once weekly albiglutide. And then later on, we had the once weekly semaglutide injectable and the oral semaglutide, which again broke barriers because oral semaglutide was able to overcome the needle phobia, right? The entire GLP-1 agonist class are injectable, but oral semaglutide comes in a once daily preparation. So that many patients are pretty much receptive. When you say that you're going to actually give them a tablet, they are far more receptive, although it is a tad expensive. They're far more receptive than the injectable class. So GLP-1 receptor agonists are now being used much more than the past. Now, on that note, the next generation GLP-1 receptor agonists are on the corner. Now, what are next generation GLP-1 receptor agonists? As shown in the slide, they are dual GLP-1, GIP agonists, right? Now, what are dual GLP-1 and GIP? So it also has the impact on gastric inhibitory polypeptide, right? Now, they are currently the GLP-1 agonists are only GLP-1, right? Now, there is also influence on the GIP, like the tirzepatide. The dual, like the Manjura, which is on the corner, should be launched anytime this year. has such profound weight reduction, almost to the tune of about 20 to 25%. So that means huge weight reduction. Again, they can now say that patients who may, require metabolic surgery, we could tell them, okay, let's, use these injections for a period of 6 months and 8 months and see the response. Of course, some patients may respond really well. They may be non-responders as well, but some patients they may be hyper responders as well, right? Where we may result in such reduction of, and particularly when these injections are used very early in the day. Now, that's something that we should be aware of, right? Now, we are looking at also remission of diabetes, right? That is something all our patients have. The imagination is caught amongst all our patients also. Today, I encounter at least 2 to 3 of my patients asking, Doctor, can I reverse diabetes, right? That is because of the social media impact, also because of the various virtual platforms focusing on reversal. Now, at this point in time, of course, along with lifestyle modification, we should never underestimate the power of lifestyle modification, which entails just not nutrition, but also regular exercise. The ADA recommends concurrent training, which is alternating between aerobic exercise and strength training. Now, combined with this, when you use a powerful weapon like like terzepatide or the once weekly semaglutide, which is there in the pipeline, I think we can make such impact in our patients. Now, particularly when used very early in type 2 diabetes, right? You don't want to wait later in the day where many OADs fail and then use GLP-1 receptor agonists. At least at that point in time, of course, you may have an impact on the weight, you may have impact on blood sugar correction, but you may not have that much of impact on reversing diabetes. So using it very earlier on, I think, would be extending the best benefits to the patient. Now, some of the other, I mentioned the terzepatide, there's also the servotutide, retatrutide. Now, these are triple GLP-1 agonists. Now, these agents are now looking at reduction of patient's body weight to the tune of 30 to 35%. That is on par with bariatric surgery. Now, both the servotutide and retatrutide may, the light of the day. They may see the light of the day in the next 2 to 3 years. But it's going to take some time, definitely. But in the next 1 year, we are definitely going to see terzepatide as well as the once weekly injectable semaglutide from Novo Nordisk. Both of them are around the corner. I think they are going to make a huge impact. Now, all of us are also aware that GLP-1 receptor agonist, after the famous Elon Musk tweeted that his the secret of his body weight is actually due to the injectable semaglutide, right? Wegovy. That's what he tweeted once, and Novo Nordisk shares skyrocketed, and it actually became a Hollywood phenomena. There is a term now called as a Hollywood phenomena because semaglutide, there is such shortage of supply of semaglutide in the Western world, both in the US and as well as in the EUs. So such effect that it tripled off in India. We actually had the dearth of both liraglutide as well as dulaglutide because we didn't have the injectable semaglutide. So we were also running short of the GLP-1 class. So I think these two molecules are going to make such a huge impact. And then coming to SGLT2, SGLT1 inhibitors. Now, SGLT2, all of us know, we know the dapagliflozin, canagliflozin, as well as empagliflozin are there with us. We've seen that they can, act independent of the pancreas, resulting in blood sugar reduction devoid of hypoglycemia, right? That's the hallmark of SGLT2 inhibitors. Again, I alluded to the effect on the cardiovascular outcome, conferring renal protection, so on and so forth, right? Now, what does the SGLT2 inhibitors do? They inhibit the SGLT2 receptors in the proximal convoluted tubule, correct? Now, the SGLT2 receptors reabsorb 80 to 90% of glucose, right? Now, if you look at the basic physiology, about 180 grams of glucose goes through the nephron every day, right? They get filtered. So now, if 180 grams of glucose goes through the nephron, if SGLT2 receptors absorb 90%, at least 150 to 160 grams of glucose should be excreted, right? But that doesn't happen. With the use of SGLT2 inhibitors, only 100 grams of glucose gets excreted. Other 80 grams are still reabsorbed. Why? Because once the SGLT2 receptors are inhibited, the SGLT1 receptors, which are there behind in the proximal convoluted tubule, end up reabsorbing the rest of the glucose. Right? Now, that's the problem. Now, what happens to the combined SGLT2, SGLT1 receptors, such as sotagliflozin? Now, over here, you may be able to actually reabsorb, actually be able to prevent reabsorption. So, excreting about 90% of glucose. So there will be more amount of glycosuria, resulting in better sugar reduction and, in fact, better weight reduction, right? 80 to 100 grams is about 300 to 320 calories. But what happens when you actually excrete about 160 grams? So it's about more than 400 and 450 calories, right? You may be able to actually impact even better on weight reduction. So that's the effect of the newer SGLT2, SGLT1 and SGLT2 inhibitors. The mitochondrial bioenergetics modulators, I think they're going to mitochondrial level, cellular level. We also have the immiglin molecules with that. Immiglin is already there in the market, but it touches the mitochondria at surface level, right? It does not actually work in the mitochondria as much as we would like. But there are other molecules in the pipeline which are actually going to change the mitochondrial bioenergetics. And then we have the novel insulin analogs. Insulin is something which is with infinite capacity. I think every drug perhaps has a finite level, limited level. Insulin has always been our go-to drug, right? Go-to drug when all other therapies fail, or we also rely on insulin when patients have comorbidities, patients have complications, patients have where we cannot use other agents because of renal insufficiency, or patient is in a critical care condition, so on and so forth, right? Now, what is the challenge of insulin? Now, insulin, perhaps the only dreadful adverse effect that we are always aware of, and which is also we have the inertia to not just initiate but also intensify, is only the risk of hypoglycemia. Right now, we are extremely worried about patients landing up in hypoglycemia at any cost. We would like keep the patients devoid of hypoglycemia. Now, we have the newer insulin analogs. We also have the icodec, which is once weekly insulin, which is going to probably help in reducing the number of pricks. That's going to happen. But there's also going to be newer insulin analogs which are going to be sensitized to the blood sugar level and act accordingly. So the risk of hypoglycemia is itself going to be reduced with even the use of insulin in the near future. So that's how the paradigm is clearly changing. Next slide, please. So as I mentioned, I think terzepatide has already been rolled out. It's already there in the Western world. It is called Manjura. It should be rolled out in India in the next coming year in 2025. I'm really excited to use this molecule. I think we have two impactful molecules, both the terzepatide as well as we are going to have the injectable semaglutide. Right, injectable semaglutide has a dose-dependent effect, 0.5 to 1 milligram for patients with diabetes. Then we have the Wegovy dose, which is 2.4 milligram. Now, 2.4 milligram is been independently approved for weight reduction regardless of diabetes. Now, both terzepatide as well as injectable semaglutide have huge impact on weight reduction. Both have been approved for weight reduction independent of diabetes. And then again, as I said, we also have the survodutide, retatrutide, the third generation GLP-1 receptor agonist, triple GLP-1 agonist also in the pipeline, which should see the light of the day in the coming years. FP-glinetide is again there. And then interesting drug is a bimagrumab, is also going to help in weight reduction, also retain muscle strength. Now, it addresses the receptors which actually promotes weight gain and muscle loss. Now, this is given once a month, where this drug has the benefit of weight reduction, glycemic control, and retention of muscle mass. Again, if we can combine it with lifestyle modification, with increased protein intake and strength training, I think we may be able to retain muscle mass. Muscle mass is extremely important, right? Because after the age of 40, we end up losing about 2 to 3% of muscle mass every year. So that is why it is so important to do strength training. And when I say strength training, it is not bodybuilding. Strength training helps us to retain the muscle mass. And particularly for patients with diabetes, when you have increased muscle, that means your insulin sensitivity is going to be better, right? The insulin receptors in the muscle are going to be more in number, right? When the muscle increases in surface area, the insulin receptors are also going to increase in surface area. So the insulin resistance is going to come down, insulin sensitivity is going to improve, right? Overall, the glycemic picture is only going to improve. Sotagliflozin, as I already mentioned, is a dual SGLT2, SGLT1 inhibitor, which can knock out almost 90% of the entire glucose load, resulting in not just better sugar control than a pure SGLT1 inhibitor, which has got affinity only to SGLT2 receptor, right? This has affinity to both SGLT2 and SGLT1 receptors, plus better sugar reduction. The dual inhibitors will have better sugar reduction as well. Next slide. Mechanism of action, I think I already alluded to. The glucagon antagonist is another aspect which is looking to reduce hepatic glucose production, particularly patients who have higher fasting, where we have trouble in addressing the fasting plasma glucose levels. I think glucagon antagonist is going to have an impact in such patients. Next slide. So the future is, of course, going to be very personalized, individualized. It's also going to be a little challenging because we have a plethora of agents already, right? Now, what makes it difficult is once the patency of any of these molecules is off, you have every permutation combination available in the market, right? Even we get confused which DPP4 is combined with which SGLT2 inhibitor, right? So, and it is probably easier in India to do a trial and get the approval of DCGI and roll out these molecules. However, I think we have to individualize therapy. Now, the advantage at this point in time with these newer agents is we can probably have a large impact on our patients, preventing them landing up in complications. I think that's where we have to make a difference in the coming years because India has the huge burden of type 2 diabetes. We have the dubious distinction of being recognized as the diabetes capital of the world. Now, the challenge over here is we've been over the years probably having a stepwise approach, right? Because we start metformin and then we wait and then we intensify with another agent, which kind of creates these window periods in between of hyperglycemia, potentially, culminating into complications in the future. Now, that has been a traditional, conventional approach, right? Now, that perhaps now has to change. Now guidelines also globally, if you see, are quite explicit in recommending combination therapy earlier on. Why now combination therapy is possible? Because combination therapy today can cut the blood sugar under control without the risk of hyperglycemia, right? Earlier, 10 years, 15 years back, if you look at combination therapy, you will have to combine it with sulfonylurea or insulin. So there is always the chance of hyperglycemia. Today, that's not the case. The landscape has changed. We can use a GLP-1, we can use metformin, SGLT2, and get the job done. So we can have a combination approach where we address multiple factors contributing to hyperglycemia, right? It's a more comprehensive approach rather than merely looking at the blood sugar levels. And we address multiple factors contributing to hyperglycemia. It is not just a comprehensive approach, it is also more durable. The HbA1c reduction is more sustainable, right? So there is no, the failure to therapy is less over there, right? So that's why even at a threshold of HbA1c of 7.5, as the ACE indicates, or 8 as HbA1c recommended by ADA, we are now looking to, of course, initiate combination therapy very earlier on without obviously keeping patients devoid of hypoglycemia. And also using these agents, we are able to address the extra glycemic benefits that we've been talking about, including weight reduction, including cardiovascular protection, renal protection, so on and so forth. Yeah, next slide. I think that should be. So some of the challenges in these newer agents is probably, I think, as I mentioned, the once the patent goes off, obviously there is a lot of combinations. That's something that we need to be a little wary of. We have to understand which combination is probably more well studied, and sometimes you will have vildagliptin as well as empagliflozin, where empagliflozin perhaps is the benchmark in terms of cardiovascular protection, but vildagliptin does not have a CV outcome trial. So you'll have to probably understand which combination could be the best for your patient. Obviously, the benefit of off-patent drugs is indeed they are quite cost effective. However, the newer agents that we've been discussing about, which are in the pipeline, are going to be a tad expensive. They are definitely going to be expensive. India is an out-of-pocket paying country, but I think how we can educate our patients is it's no point spending after landing up in a complication, spending lakhs of rupees. That is something that all our patients understand. They are in tune to it. In fact, that is something has to change. Rather than shelling all the money and then still the quality of life is going to get affected, right? The patient may not be the same again after a cardiovascular event or a renal event. No point spending at that point in time. What is wise is to probably, spend early, gradually. We would be able to prevent and delay complications. Now, these are drugs which have survival benefits, right? It actually extends the lifespan itself, right? So that is something that these drugs bring to the table. That's something we need to spend time and educate our patients, because considering the chronic nature of the disease, we also have to understand that it is indeed expensive, that we have to educate our patients more, bring in that awareness, and then I think they would be sensitized and receptive to these newer agents. Next slide. Yes, as I finally to conclude, I think the future is indeed exciting. Future is exciting. There are not just in terms of the therapeutic agents, there is also technology. We've seen how the Abbott Freestyle Libre, the CGMS, continuous CGMS, has given us deeper insights to patients' glycemic variability. Right now, we know how to kind of titrate our drugs, insulin to micro level, understanding patients' glycemic variability. Now, the future, not just we have so much therapeutic options, we also have more and more technology, remote monitoring solutions. We also have the Eversense, which is a 6 month like Abbott Freestyle Libre sensor. This sensor can be implanted in an OP procedure, for then the sensor will lie in the subcutaneous tissue for about 6 months, which gives us glycemic variability. It's going to be not just for diagnostic but also for therapeutic benefit, where we will be able to address hyperglycemia, the time in range. As we know how HbA1c is important, now the newer concept is time in range. So with these newer technologies, we'll be able to micromanage our patients and do far better. So that's how the paradigm is changing. I think the future of diabetes management is going to be quite exciting. So with this, I would like to conclude my talk. Thank you.
Thank you so much, sir, for this wonderful presentation. We do have some question if you like to take that up.
Sure, sure.
So, sir, the first question was, what are the key differences between the newer classes of anti-diabetic agent, such as GLP-1 receptor agonist or SGLT2 inhibitors and DPP-4 inhibitors? Uh, Due to some network issues, sir has left the platform. He will be joining soon.
Sorry, sorry.
Yes, sir. No, no, sure.
Yeah, so both the DPP4 inhibitors and GLP-1 receptor agonists are incretin-based therapies. Now, DPP4 inhibitors increase the native GLP-1, meaning all of us have the GLP-1 hormone, which is secreted in the intestine. However, its half-life is only 3 minutes. It gets cleaved by the DPP4 enzyme. Now, what the DPP4 inhibitor does is it inhibits the DPP4 enzyme, allowing the human GLP-1 to survive long. Right? That's what the DPP4 inhibitor does. But the GLP-1 receptor agonist achieves supraphysiological levels of GLP-1. So it is not just the normal human GLP-1 level. It achieves supraphysiological level. About 8 to 10 times of GLP-1 levels are achieved, and that not helps to achieve better, not just better sugar reduction. Incidentally, the supraphysiological levels of GLP only has effects on the hypothalamus, thereby increasing the satiety, which means we have less hunger, better weight reduction. Also has shown cardiovascular benefit. Also has shown renal benefit, and so on and so forth. So that's the difference between DPP4 and GLP-1 receptor agonists. SGLT2 inhibitors is completely a different class. They act on the kidneys. They act on the proximal convoluted tubule. What they do is they, in fact, earlier patients used to say, patients when they have glycosuria, when they have 2 plus in the urine, they used to get alarmed. Now that's not the case, because using SGLT2 inhibitors, they knock out the sugar through the urine, and that's now considered as the benefit, because rather than disposing of the sugar inside the system, these drugs excrete the sugar out of the body itself. That also seemed to have some benefit, weight reduction, so on and so forth. So that's the class of SGLT2 inhibitors.
Thank you, sir. There is another question. How do this newer agent compare with traditional anti-diabetic medication in terms of efficacy and safety?
Of course, yes. It's a very good question because metformin, sulfonylureas, we have a wealth of evidence. They've been safe. We've understood its efficacy. Obviously, the newer agents, the RCTs are studied only for about 3-4 years duration. We know the benefits, but once they are rolled out, the real world scenario can be sometimes different, right? So obviously, we have to be aware whenever we use these newer agents. Some known side effects are documented, like GLP-1 receptor agonists. We cannot use them in patients with a history of pancreatitis or a family history of medullary endocrine carcinoma, thyroid cancer, so on and so forth. These are black label, this cannot be used. The other common adverse effects like nausea, vomiting are known adverse effects, which can be largely overcome with education as well as with time. GLP-1 receptor agonist does cause nausea, but after about 1 to 2 months, it can be it is usually reduced. But then the newer triple GLP-1 agonist, we have to wait and watch once they come into the real world. There will be real world studies as well, but we also have to be vigilant in looking at our patients when we use these new agents.
Thank you, sir. There's one last question. What role do this agent play in addressing comorbidity such as cardiovascular disease and kidney disease in diabetes patients?
Increasing or decreasing? What is the question? What does?
Sure.
Can you
Let me
repeat the question?
just, yeah. What role do the agents play in addressing comorbidities such as
Correct, correct.
cardiovascular disease? Yeah.
Huge, huge. That's why these have such euphoria with them because probably I would say GLP-1 receptor agonist is probably the most powerful weapon in a diabetologist armamentarium. That is, I think, the single most powerful weapon. Why? Because they address the entire metabolic spectrum. They have an effect on patients' body weight. They have effect on patients' blood pressure, blood sugar, lipid profile, and then finally they have an effect on patients' cardiovascular, as we've seen from the leader trial as well as the sustain 6 trial. All of it have showed significant reduction in cardiovascular mortality. This is on top of standard of care. So that means there are two arms. The other arm, patient has statin, aspirin, antiplatelets, everything. Both arms have. The in the intervention arm, there's only GLP-1 receptor agonist. So on top of the best of care, they were able to reduce cardiovascular mortality compared to the best of care. Right? That's the kind of impact they have brought to the table. That's why they have a huge impact on cardiovascular reduction. And SGLT2 inhibitors have an impact on heart failure as well as renal protection. GLP-1 receptor agonists probably have an effect on atherosclerotic cardiovascular disease itself. Yeah.
Thank you so much, sir, for answering all our questions. That's all from our audience. Before concluding, sir, any take home message from your end?
I think take home message would be to use agents very early on in type 2 diabetes. Today, we have to achieve stringent levels very early on. When we achieve stringent levels, I think we can prevent these patients landing up in complications. That's probably the huge burden that we've been facing in India because we have such number of patients living with type 2 diabetes landing up in complications, and then we see the number of patients landing up in dialysis, landing up in the cardiologist's hands. I think that's something that we can now create an impact, probably confer cardiovascular renal protection, use these drugs very early on. So change that course and prevent them from, and also having such good, providing them with good quality of life. So use these agents very, very early on in type 2 diabetes.
Thank you so much, sir, for joining us today. With your permission, I would like to conclude today's session. Thank you.
Thank you very much.